for Concepts in Imaging Technology, RADT 50. This is abdomen anatomy and positioning. The abdominopelvic cavity extends from the diaphragm superiorly to the bony pelvis inferiorly. There are two parts to the abdominal pelvic cavity. We have the abdominal cavity, which is larger than the pelvic cavity. Makes sense, right? The abdominal cavity contains your stomach, small intestines, large intestines, liver, gallbladder, the spleen, the pancreas, and your kidneys. The pelvic cavity, fewer anatomy, has the rectum, the sigmoid colon, the urinary bladder, and reproductive organs. It's a combination shot of the abdominal pelvic cavity with the anatomy labeled. Patient preparation for an abdomen x-ray. T-shirts should be fine, but buttons on shirts might show up, so those should be removed. Elastic waistbands, if they're too tight, can cut into the anatomy of interest and show up as a visual artifact. Bras and most pants must be removed. Underwear stays on. If your patient has a navel piercing, that should be removed. So an example of dressing instructions you would give for an abdomen x-ray. For this exam, you'll need to remove your shirt, bra, and pants. Keep your underwear on. Please put on this gown. It ties in the back. I usually tell patients, take out everything except your underwear. So shirt, bra, pants. Underwear stays on, socks and shoes can stay on, but we're removing other artifacts. So buttons, metal zippers, very tight elastic, those would all be problematic. Distance is a bit different for an abdomen versus the chest x-ray. You may recall for the chest x-ray, we had a distance of 72 inches. For a supine abdomen, you will use a minimum of 40 inches. 40 to 45 inches is preferred if you can achieve that. 40 inches is standard for an abdomen projection using the table, but more distance is better. So you can increase to 45 or 48. ID marker, right or left, must be included. The best place for that marker is the bottom corner of your detector or your cassette. Radiation protection. We need to shield male patients below the pubic symphysis. Unfortunately, we are unable to shield female patients for an abdominal exam. That would put a lead shield over the pelvic cavity, blocking some anatomy. So we typically do not shield for the supine abdomen for female patients. That makes your check for possible pregnancy so much more important. And you might even emphasize to your patient, I can't shield you for this image. So just double checking, no chance of pregnancy. Some facilities may even order a pregnancy test for imaging below the diaphragm. Supine abdomen, referred to as a KUB, that stands for kidneys, ureters, and bladder. Kidneys you will see faintly on the image. Bladder you might see if there is liquid in it. Ureters you typically do not see without a contrast medium. Key X-ray landmarks. This is copied from the body planes PowerPoint. For an abdomen, there are several bony landmarks that we need to feel to make sure we are centered properly. Primarily, for KUB, it's the iliac crest. So this is the uppermost ridge of the pelvis. If you press in on your side, you will feel a flat ridge. So you want to be right in the mid-coronal plane. So as if you were being cut from front to back, directly in the center, kind of where the armpit plane is, the mid-axillary line. To press in with your thumb, you will feel a flat ridge. So you don't want to slide forward or backward. You want the crest itself, the top of the crest, directly midline of your patient. Another very useful landmark is the anterior superior iliac spine, or the ASIS. This is the front edge, the anterior edge of the iliac crest. If you put your thumb back on the iliac crest, right at the top of the pelvis, and then you slide your thumb forward, you will feel a flat portion close to the surface of the body. So this is about where you would have a pants pocket. You should be able to feel this easily because it sits very close to the anterior surface of the body. So that's the ASIS. We use those to check for rotation on a KUB. Also crucial for a KUB is the pubic symphysis, also known as the symphysis pubis. This is the joint where the two halves of your pelvis articulate. This can be palpated. If you press in just below the bladder, you will feel a bony ridge. This is the lowest point in the abdominal pelvic cavity, and it has to be included on the KUB. If you have clipped it, you have to do a supplemental image, because otherwise the radiologist cannot determine that all of the abdomen was included. This is a point that lies 3 inches inferior to the ASIS. So if you can feel the ASIS on your patient and you go 3 inches inferior to that, you should be at the upper margin of the pubic symphysis. Now, we don't necessarily want to be pressing in on the bladders of all of our patients. So there is an alternative landmark that you will check when you are positioning for this projection to make sure that you have included just the upper margin of the pubic symphysis. We don't need the entire joint visible, just enough to see that you have all of the abdomen visible. So the alternative is here. This is the greater trochanter of the femur. So I want you to put your thumb or fingertips on the lateral edge of your upper leg by your hip. Again, kind of near where you would have pants pocket. And I want you to swivel your leg back and forth. Just roll it in and out. Your hand, your fingers are on the side of your leg. You roll those back and forth. Roll that leg back and forth. You will feel the greater trochanter shifting underneath your fingers. That block of bone where muscles attach lines up with the superior portion of the pubic symphysis. And you can see that here on this illustration. The greater trochanter is in line with the pubic symphysis. So when you are positioning for this projection, rather than poke around below your patient's bladder, you can feel for the greater trochanters and not have an embarrassing palpation for you or your patient. To obtain a KUB, we want your patient supine on the table without rotation. This means they're not favoring one side or the other. They can bend their knees if that's more comfortable. Your central ray should enter the mid-sagittal plane at the level of the iliac crest. we're going to open our collimated field to the dimensions of our cassette, 14 by 17 inches in a lengthwise orientation. So bigger up and down than side to side. You have a digital detector. You can set it to these dimensions. And if you have a smaller patient, you're going to bring that light field in. You're going to restrict the X-ray beam to an inch outside the skin line. Most patients, you will just be having the full 14 by 17 field. Now this does vary based on body habits. If you have a hypersthenic patient or you have a large obese patient, the lengthwise orientation will clip off some anatomy. So we turn the cassette crosswise, again, looking like an envelope, and we do two projections, one getting the lower portion of the abdomen, one getting the upper portion. You may have to do a supplemental image on a very tall patient as well to include all of the large intestine or to get the pubic symphysis visible on the image. Here's an example of centering for a KUB. The pointer there indicating the central ray entering the mid-sagittal plane, fairly close to the belly button, but don't rely on the belly button. On the larger patient, it's not going to be in line with the iliac crest. We are centered to the crest, here and here. Light going down to the pubic symphysis, which you cannot see, but if you could palpate the greater trochanters, they would be included. This patient should have a lead shield. This is a male patient, but a lead shield just below the light. It will not be blocking the pubic symphysis, but it will protect the gonads. Also note that this patient has breathed out all the way. We obtain a KUB image on full expiration. And what this means is the patient exhales fully, then stops breathing. This compacts the thickness of the belly, which means we don't need as many x-rays to get through it. We can save the patient some dose. Also on expiration, the diaphragm moves superiorly. So instead of having lung fields visible in our image, we have just the abdominal contents. For a supine abdomen, you should see evidence of proper collimation, meaning the boundaries of the cassette are visible. We should include anatomy from the pubic symphysis to the upper abdomen. So if your image has clipped off part of the large intestine, you need a second picture. You may need two images if the patient is tall or wide. Proper patient alignment, so the vertebral column should be centered. Ribs, pelvis, and hips should be equal on both sides. That indicates that your patient is not rotated. More checks for rotation. The spinous processes of your lumbar vertebrae should be in the center. Ischial spines of the pelvis should be symmetric. These are not always visible. But the wings of the ilium should be symmetrical. I have an image coming up where I'll show you what that looks like. The two broad butterfly wing shapes of the pelvis, or elephant ear shapes, should look equal on both sides. We should have enough brightness and image contrast to distinguish the wall of the abdomen and the psoas muscles. You should see the margins of the liver. Kidneys should be visible. Right or left marker should be visible. In the bottom corner, it won't be overlapping. any abdominal contents, it might be over the hip joint, but that's okay. Here is an example of a KUB, kidneys, ureters, bladder. Abdominal contents going down to all of the pubic symphysis is included here. Let's look at a labeled version of this image. Now the anatomy is highlighted for you. We have a gastric air bubble up top, so air in the stomach. Next to that is air in the large intestine, in this case, the splenic flexure or the left colic flexure. That is the point at which the transverse colon curves and becomes the descending colon. Tucked behind there is the spleen, left kidney and right kidney outlined, liver on the right side, so as major muscles draping like curtains lateral to the vertebral column. And below, in the pelvis itself, there's the urinary bladder, and below that, the pubic symphysis. So if we go back to our unlabeled image, you can see the margin of the right kidney and the left kidney over here. You're actually seeing the fat that surrounds the kidney standing out against the abdominal contents, because the appearance of fat on an X-ray is different from the appearance of muscle. They absorb at a different ratio. So liver, gastric bubble, air in the colon, air and stool in the ascending colon over here. So as major muscles, your iliac crest, and if you look at where your X-ray is centered, mid-sagittal plane, about at the level of the crest. Anterior superior iliac spines are here and here. These are the wings, or the ala, of the ilium. Ischial spines are these little triangular projections here. As long as they look equal, it indicates there's no rotation. We have a digital marker instead of a lead marker. Lead marker would be better. Pubic symphysis. These are the obturator foramina, and they look equal. That also indicates no rotation. Another labeled image here, KUB, pointing out some spine anatomy on the lumbar region, but you can also see the iliac crest, ASIS, intestinal gas, pubic symphysis. This is an IUD. And do we have all of the abdominal contents? I'm not certain that we do. We might need a supplemental picture because there is some transverse colon clipped off up here. There's also some rotation on this image. This KUB, just pointing out some of the harder to see anatomy. Dashed line indicates the margin of the liver, the inferior margin of the liver. Dotted lines are the kidneys. The dots and dashes indicate the psoas major muscles. Now, if you notice on all of these images that the kidneys are visible, the left kidney is superior to the right kidney. This is due to the presence of the liver. Large liver kind of pushes the right kidney down. So you're always going to see the right kidney more inferior to the left. This is a KUB with some motion. In this case, motion from the patient breathing while the exposure was made. You will sometimes see motion from bowel contents moving. We can't tell our patient to stop digesting food. So sometimes there will be movement within the intestines themselves. You cannot control that. But in this case, the blurriness that you see up here is because the patient was breathing. Note, it's not blurry down here because this portion was not moving. The lungs were moving. You can see bladder contents here. The patient has a full bladder. And we have part of the pubic symphysis visible, not all of it, that's fine. We don't need all of it. We just need to see that separation, even just a glimmer of it. But if that's clipped off, then you need to do a supplemental picture. This is a suboptimal KUB because the centering has been poorly achieved here. We have too much anatomy below the pubic symphysis. Also, this is a larger patient and would benefit from 2 crosswise orientation cassettes rather than 1 lengthwise image. Because not only do we have unnecessary anatomy down here, we only need just that split visible. So we've centered, we are centered too low. We've also clipped off anatomy. Note that we don't have anatomy here. We have some abdominal contents on the left side that are clipped off. If you have a patient with a lot of fatty tissue, it's not necessary that you include all of that fatty tissue, but you do need to see the intestines visible. So we're close on the right side here. We've clipped up top, we've clipped on the left. For larger patients, you may be putting together a series of images with overlapping anatomy so that the radiologist can see, when you put them all together, it's not going to assemble onto one super image, but they can look for common parts and make sure that everything is included. So in this case, this patient large enough that we required 3 images rather than just 1. On the lower portion, we have more below the pubic symphysis than we need, but look at these bright metallic objects. These are landmarks for you to compare to the other images. You can see they're visible on the other 2. Obviously, if you just center, if this was your second shot, you would need a third because we've clipped off the left anatomy here. So note the difference between the large intestine and the soft tissue beyond that. This is not as important as making sure all of the intestine is visible. Here's what rotation will look like. This is a lot of rotation, but it's a good example of what that will do to your image. I want you to look, there's not much rotation up top, but the pelvis is rotated significantly. And you can see how much it's turned. Notice the difference on the width of this portion of the ilium versus this portion. This is elongated, it's rolled down against the table. So this patient is turned to the right. The left side has come up off the table. It now looks narrower on the image because it's pulled away from your cassette.